And so I'm referring to that as the updating of the Canadian Consensus Guidelines from the 2018 version and possibly internationalizing them for the next iteration, which possibly would be 2028. And then just to talk a little bit about the next steps for that. So the focus is the primary health care of adults with intellectual disabilities, and really what we've learned from all that. So I just thought I'd begin by saying this is my first time to Greenwich, a lovely place, and thank you for the warm welcome. Other people in the audience, first time to Greenwich? Okay, so you people, I have a question for you. What is this? I learned this yesterday. So what's this image, do you think? Any ideas what that is about? It's something that is just up the hill. It's at the Royal Observatory. It's a very funny looking contraption. It's a first of its kind. Any guesses what kind of instrument it is? It's a clock. It's a sea clock. It's called the H1. And I'll tell you what that means in a minute. But the technical term is a chronometer. Chrono meaning time, meter, but it's for the sea. And this is very important historically, which is something that I learned. And it sort of has to do with something in this image. So this image is also just an image from yesterday of the globe. And it's showing intersecting lines. So there's the horizontal lines that go up, latitudes, parallels, but there's also a vertical line. And this particular line cuts right through, the globe from north to south, and is quite close to places where I've lived, Toronto, Canada, and now Washington, D.C. And so what's this called? The up and down line. Well, these are meridians or longitudes. And so basically the idea is that if you can look at the whole globe, 24 hours in a day, divide it up into hours, each of those hours apart represents another longitude, just by sort of convention. So then this is the next question. Again, something that you will learn if you have a bit of time in Greenwich. Who is this guy? And why is he famous? So I didn't know who it was previously. Sorry. But this is a guy named John Harrison. And those are the dates he lived. And John Harrison solved the most important scientific question of his time. And he did it in a way that has something to do with what I was just showing you, the longitudes. And he did it by these devices. The first one that I was showing you was H1, means Harrison 1. The first clock he built, he was a carpenter, didn't have any education, and he figured this out by the time he was 19. He comes from York. But this was the first sea clock that he developed, and nobody had seen anything like this. It weighs about 75 pounds, but it's built to go to sea. He'd never been to sea. He'd never even been exposed to clocks, right? And he figured this out. That's one. This is two. The next one that he built has more sophistication. The first one was already ahead of its time. It did not need to be oiled, for instance. It could withstand temperature changes and movements and still keep time. This one is a bit more complicated. Then this one. So H3. And some of this stuff in H3 we still are using today. Won't get into too many details, but he was able to combine metals that would counteract the what cold and heat causes metals to do. And so we still use that in thermostats today. That it's called a grid iron. And then the other thing is, again, no oil needed, because oil doesn't do so well when you have heating and expanding. And a third one was all the sort of gyrations of a ship. This would counter it and keep the time. So this was H3. But all of this was in the context of a very big prize that was legislated by Parliament in the UK to solve the longitude problem, because it was a huge problem of people getting lost at sea. And nobody thought, almost everybody was looking up at the heavenly clock to solve this problem. He was the only one that was looking at a clock to solve it. And this is what won the prize. His number 4. And just to say that it doesn't look like it's in continuity with what predated it, but it is. But it's much more compact. You can take it to sea. It's closer to a pocket watch. They never thought anything small could be accurate. But the question of all this is can you implement this? And this was part of the prize. It had to have a practical impact. So the first thing it had to do was to be accurate. So on the first time it was tested at sea, it was actually January 19th, they left Britain for Jamaica in 1762. And after 81 days on sea, hot, cold, up and down, storms, etc., they arrived in Jamaica. They checked the time. So they were able to check exact noon time. They had people from Britain that were there, the astronomers, to figure out that this was exactly noon. So they knew exactly what time it would be back here in England. And then they looked at the watch. 5 seconds off. Imagine that. Never been done before. And so it passed that test. What 5 seconds means after such a journey is about 10 miles of error, which is very remarkable. It passed that test for the prize, but was it practical? It took he had to reproduce it, and it took 6 to 7 years to make and to perfect, to make sure that it was working exactly right. So there were, by the end of his life, there were only 2 such clocks in the world. So is that practical? This is all going to be relevant in a moment, what I'm going to talk about. But this is the next thing. Everybody that's here has never been to Greenwich. You're going to get a photo like this. What am I standing over? The prime meridian. So the reason why this is interesting is that there were several prime meridians for the longest time. All it means is that this is where you start from for time, for the 24-hour clock. You have to start somewhere. And so this is just showing that. But it was actually just by way of a convention that was held in Washington, D.C., 1884. So, quite a while after the 1762 voyage, that actually the then president of the United States invited representatives of 26 countries to come together and just decide where we're going to set the prime meridian, because there were many competing possibilities, and 22 of them voted that it would be Greenwich. So what I just showed you, they said, let's just decide Greenwich for various reasons. But some abstained, and it took them a while to kind of, move over to let's just accept that this is where time will start for the whole world, right? This is for the whole world, and it's been that way ever since. So why is this relevant to what I'm going to talk about? So the first thing is consensus. And when I talk about these consensus guidelines, it's a bit like that meeting. That meeting actually took more than a month for them to vote and agree. We normally, when we're doing these guidelines, we have 2 or 3 days to debate things. But this is what it looks like. Small groups, they've already come prepared. Everybody's read stuff. People have made proposals of what we ought to think about as a recommendation by peers, family docs working in this area, to our peers that don't have much experience or as much experience. They haven't read the stuff. But what could we say that might be useful to them? And this is how it gets worked out. When I showed you, I'll show you in a minute, the 2018 guidelines, and that what's interesting is the co-authors, that's not everybody involved in the consensus process, was 26, just like what happened in Washington. And 22 of those are either our primary care clinicians who are also academics. And again, 22 voted. So it's just an interesting coincidence. But the whole idea is that this is advice by people who have been in the trenches, thinking about these things, reading about these things, to our peers. No pharma involved. No pharma would ever sponsor this, right? Also, but anyway, and it's actually the other dynamic is it's peer to peer. You know, we're not claiming to be experts. We've just had the advantage of learning from a lot of mistakes we've made, trying to help our peers. So, a little bit of analogy between the Harrison clocks and what we're up to that I just want to share with you. So the first set of guidelines was in 2006. And it was in a context in Canada when there was a decision to close all the institutions that were housing adults with intellectual disabilities. And part of that context was most of our training of medical students and most of our practice where we're teaching medical students, we didn't have any adults with many adults with intellectual disabilities. They were all in the institutions. So we didn't know what, like primary care providers, needed to get up to speed to care for folks in the community. And we didn't know what we should be thinking about that would be different. It also comes on the backs of a tradition in several countries, not just Canada. Canada actually has a fairly old tradition of preventive care task forces. So this is what you have a group of people that look at what's been published, what are people dying from, and try to come up with recommendations for the general population for mostly preventive health care. And so we realize that, well, what the general population is facing is not the same thing that people with intellectual disabilities are necessarily facing. Some of them will be similar, but there may be differences. We didn't know what those differences were. So that was sort of the context of the first guidelines. And remember, we're talking to family docs who will get involved mostly and be primarily responsible for the adult population. We also in Canada, as elsewhere, have others who help out up to age 18. So that was another reason for focusing on adults. But of course, that transition into adulthood is a huge issue that is of concern to both groups. So 5 years later, 2011, after we did the first guidelines, and by the way, we brought in people from Australia, US, UK to help us, the experts of the day. You guys know a lot of these people, but Nick Lennox, for instance, from Australia, very important. They've done a lot of work, and so we benefited from that. So in a sense, they began as from an international perspective. But we did training, and by training people, we had questions like, how do you do this? You know, there would be a recommendation, say genetic screening, and how do you actually do this? And so out of that grew a set of tools. So by 2011, we had a tool book, a paper book, English and French, explaining the how-to about various guidelines. And so in a sense, that was also a move toward implementation. The other thing that was important in 2011 is that one of our colleagues, Yona Lunsky and her team, did a primary care atlas of people with intellectual disabilities in Ontario, largest province of Canada. And she had a data set of 67,000 adults, and looked at what are the common health issues. And there were some surprises. And so that became an important evidence base for the update. And then the next set of guidelines came 7 years later, 2028. And that's what I'm mostly going to focus on. It's like the H3. But the key advance there was method, and to how to think about evidence for this type of guideline. And then we're looking at 2028, just an arbitrary date, but that would be 10 years after the publication of the last guidelines. And the question that we're raising now is, if it's going to be valid, you really have to update it so that people have up-to-date information and thinking about these recommendations. So this is the guidelines. This is our Canadian Guidelines 2018 publication in the Canadian Family Physician. So primary care of adults with intellectual and developmental disabilities, Canadian Consensus Guidelines. And it's kind of carrying this sort of tradition forward. It was published in the Canadian Family Physician, so that's the main journal for family physicians in Canada. It's also available freely online, English and French. It keeps to the consensus process of guideline development that we'd used in prior iterations. So I'll just give you a very quick sense of sort of what these guidelines look like. So this is what we carried forward more or less from the 2011 guidelines, that we're talking about physical health issues, and it's all about things that you wouldn't think about if you're a primary care provider, because in general, people with intellectual disabilities might have different issues to think about that are much more common. And then similarly for mental health and behavioral issues, it's what's different, what you need to think about that's new. But what was actually new in 2018 was this section, approaches to care. So it's all about, previously we had matters that are relevant to all guidelines, like, polypharmacy, things like that. But now we're kind of looking at what is it about the how that you provide care that's very important for people with intellectual and developmental disabilities. So the guidelines are meant to be comprehensive and mainly primary and secondary prevention. So with the updated guidelines, we also published 2 special issues of the Canadian Family Physician. The first was for younger people, especially this complex transitioning into adulthood and related issues. And the second was as people are aging. So a series of articles that reflect thinking in the guidelines about these different issues. Again, further help to implement the guidelines, and a more in-depth account of the new thinking about these things. So in 2011, we published paper tools that were a book and they went to every family physician in Canada. By 2018, it had all moved to online, freely available, and we have in Canada models for this that we kind of tried to emulate because they were very successful. This sort of tool approach to how to do things. So one of the things about this is they were freely available, no cost barriers. The other thing that was a bit different is that some of these tools that were updated incorporated new themes, new thinking that was not in the previous tools, but consistent with the new approaches to care. A big one was trauma-informed approaches to all care. So that sort of influenced all these updates. And I think the other thing that is part of this is just to flag, we also had a series of, or have a series of what's called health watch tables. And these are meant for people who have a known cause for their disability. For instance, health watch table on Down syndrome. So what is it that in 2 pages you need to know about that is relevant to the care of that population? Now, just to make the point, the guidelines include everybody with a disability. They don't distinguish between those who have a known cause and those who don't. But we realize there's a lot more to know about if somebody has a known etiology. But the most important thing about the update was the method. That's what's new about Consensus Guidelines 3. And I'm showing this picture because I regard the folks in this picture as a kind of John Harrison of methods, thinking carefully and deeply about how do we think about evidence? How do we think about what we're trying to synthesize and share for the context of individual clinical encounters with people? And so people might know these folks. This was from an IASSIDD meeting in Australia. Luis Salvador Carula, based there, and Sue Smith, both important work that I'll talk about in a moment on thinking about method. And my colleague Heidi Diepstra, who's now has the role I had when I was in Canada. She's the lead of the Developmental Disabilities Primary Care Program. And it's that program that has been responsible for these guidelines. So just a couple words about the new thinking about method, just a few highlights. So the issue is, how do you frame scientific knowledge for healthcare research? It's a framing question. Again, this is Luis Salvador publishing in 2014, 2015, talking about evidence-based medicine. And what are some limits of that, especially for the care of people that are as complex as the group of people we're thinking about, and talking about a new framing approach in guidelines development to manage different sources of information. So the point here is that the tradition of thinking about evidence actually comes from the university I trained at, McMaster University in Hamilton, Ontario, and it's called evidence-based medicine. And these folks came up with this idea of how do you think about evidence. The question that Salvador Carula and others are asking is, does it really capture the full range of knowledge that ought to be present to inform clinical decisions? And they thought not. So I was honored to be invited to be a co-author on this topic, moving from the evidence-based pyramid to the Greek temple, just a metaphor, but thinking about guidelines as implementation tools. This is in a mental health context. Salvador Carula is a psychiatrist, but it also holds for other contexts. And then the guidelines, and this is an article about the method related to the 2018 guidelines. I believe it was the first guidelines to employ this new thinking in thinking about synthesizing knowledge and evidence. So, traditional view. Guidelines are about aggregate evidence of the many. And it's to standardize care. So people have a kind of a common reference point of thinking about how to provide clinical care. So the idea, though, of guidelines as implementation tools is that you're going from the many to the one, to the clinical context of making good decisions for people who are specific persons in complex contextual circumstances that are dynamic, they're changing, and high degrees of uncertainty and ambiguity. None of which this research on the many actually helps you with very well. And so the idea is to not reject that, but to see that it has to be supplemented by additional types of knowledge in order to really be helpful in making prudent decisions. So this is just another image to talk about this. So the idea is that we've gone from this pyramid of evidence-based medicine. It's about the many. And it's a type of reasoning that's called deductive or inductive. But it's basically going from the many to the one, or insights of a few generalized. That's the type of reasoning. And it also privileges certain types of knowledge, especially knowledge about interventions that can be studied using randomized controlled trials, and systematic reviews of such trials. That's way more important from this perspective than people with clinical experience or lived experience. Lived experience isn't part of evidence-based medicine, by the way. So this is another model. So it's not to reject this empirical evidence, but to say that there's additional complementary knowledge that becomes very relevant at the level of clinical deciding. And so the guidelines have these categories. They all start with an E because we wanted to avoid any impression or message that there's a hierarchy, right? You can't stack them up, one more important than the other. They're complementary. That was the message. And you'll see experiential is pretty important, right? What that means is the experience of people with intellectual disabilities and their caregivers, and expert knowledge. That means people like the folks we try to bring together to make these consensus, who are clinicians, academics, lots of experience in caring for adults with intellectual disabilities. This isn't actually, I'll mention this in a moment, but this isn't kind of the full range of things, of types of knowledge. And as we're moving forward, we're going to be thinking about additional pillars that weren't part of this. So for instance, culture as a type of knowledge that becomes relevant, especially when we're talking about international guidelines. So, so one is synthesizing the knowledge, but then it's another to then make recommendations. And so this was another innovation in 2018, is it's sort of modeled on something that's called grade and agree. So these are different methodologies, but it's to make recommendations about how strongly something is being recommended and what kind of evidence is in the background. And so we basically had strongly recommend or recommend. And essentially, to be a strong recommendation, it's sort of applicable to most contexts. And there's a sense from what we know that most people with intellectual disabilities and family members would be open to such an intervention. Whereas if it's a recommend, there's other considerations are needed. The variability of context, available resources that you have. Do you have teams and others to help with various things? Values, preferences. And so more discussion is required. And then the other thing that was new was just, in a sense, one pushback is there's too many recommendations. And so we had the leads of each section pick what they think were the most important ones. And so each section has 3. And that's to kind of just highlight that, this is what we think is most important to bear in mind that's new. So just as an example, we've got this topic. It's called capacity for decision making. And it's sort of introducing this notion of shared and supported decision making. And we thought that the group thought that this should be a strong recommendation. And the other thing is the evidence here that's cited is actually not great because it's expert and at least the background consideration is also based on experiential reports. People with developmental disabilities really want this. And it was also a top pick. So for this first section of the guidelines. So at that point, there wasn't the evidence that we actually have now. It's a much, I think, stronger evidence base. So just to kind of summarize, kind of the main methodological advances are to start thinking about guidelines already as implementation tools. So this distinction between, you guys develop recommendations out there, and then another group says, oh, here's how you do it. Well, the two from the get-go have to come together, I think. And the distinction was deciding what to recommend based on lots of considerations, what's been published, and what we think, what our experiences with what people with intellectual disabilities think, et cetera. What should we do? And that would be a guideline recommendation. But then how do you do it? And that would be a tool. And so for the example of supported decision-making in Canada, that tool takes into account the full range of legal contexts in Canada that may or may not have anything supportive of this approach to care. But it's still, even in contexts where that's not present, the recommendation is still made. Do as much as you can to involve people in these decisions. So this is just the example of the decision-making tool. And just to say that a lot of thought went into this because it was all new to us, but this key distinction between people that are able to make decisions with supports independently, or are they interdependent decision makers with all kinds of supports and accommodations, or is that not possible? Certain vulnerabilities, et cetera, might make that not possible. And so that would be the third category. And I think that the key move here was how to assess the range of capabilities and vulnerabilities and legal contexts with adequate supports and accommodations. So the shift in thinking was, it's not a capacity assessment of you in isolation. It's an assessment of your supports, your support needs, and what's been offered. So it's quite a change. And the default is everybody ought to get adequate supports so that they can be involved as much as possible. And in Canada, the real proponents of this would say that there should be very few people in that third category that, somebody else has to take over in a sense. And so we are actually working on working that out, how to kind of assess such vulnerabilities and support people. But that's just an example. So this kind of meeting follows up on a previous discussion that was held in Chicago. It was a roundtable at the World Congress of IASSIDD, where we talked about this. And one of the questions was, well, so what's new? Do we have new things to think about to justify all the work that goes into updating the guidelines. And yeah, there's quite a bit that's new. And so there was a pretty strong recommendation that there's enough new that it's worth updating. And I think a key thing that's new is greater clarity about guideline methodology. And I'm going to talk about that a bit more in a moment. And then there was also a question about possible new topics that we should think about. So on the methodology, and this is where I think the clarity regarding how clinical deciding has to integrate kind of knowledge of the many that we were primarily working on by thinking about what's anybody actually doing when they're making a decision, regardless of who it is, and that there are these different components. And so the acronym is GOALS. A is the agent, whoever is making the decision, or it could be plural. G is what it is that they're hoping for. Nobody is hoping for something that's not helpful in some way, right? It's always to improve something. But this is the tricky thing, the context, complex, dynamic ecosystems, and how to think carefully about that context that you are intervening on options. So any intervention is regarded as an option to a life system to help that system, complex and dynamic, to approximate something that's better. That's a methodology for thinking about this. The acronym is GOALS, just to remember it. But another key point is it's all within relationships. We are all essentially relational, and those relationships matter and are important. So just a few points on each of those elements. The agent. So in the 2018 guidelines, it was mainly peers talking to peers, giving recommendations. What we didn't do well, that we have to do better, is this following thing, including people with intellectual and developmental disabilities and support people, and involving them in both developing the guidelines and implementing them. And the question is, how do we actually do this better? So that it's not just about the decision, helping people make decisions in a kind of a supported decision-making context, but actually developing all our thinking about the guidelines with and involving people with lived experience. And then this whole issue of this distinction between the complex life systems and the goods. In the past, it was primarily about preventing illness or injury or managing symptoms. But what does that say about flourishing? You know, isn't the good a little bit more robust than being safe? And so that's the question. What have we missed by this approach? You know, to think more broadly about the good of human flourishing that is multi-leveled. Health is a conditioning, for instance, even making involvement socially in helping to make decisions, that's a good. Even on a spiritual level, particularly end of life, nowhere in the guidelines. So thinking a bit more broadly about that, what's important to people with IDD? If we're making guidelines essentially to help them to flourish, we need to hear from them. And maybe the other thing is more accessible formats and tools that are actually developed with and for people, kind of translating some of the guidelines for people with intellectual disabilities. And then kind of the last question is internationalizing these. And so it's a tricky question, and it's, I think, a big challenge. But part of the UN and the WHO goal is health for all. And so we can do the best guidelines and really help people in the developed world with developmental disabilities if we did that well. But who are we missing? It's a big percentage of the world population, like 90%, we're missing because they're not, in the developed world. And so the question is to think about this